How are your studies going these days? I know you're trying your best to stay consistent, and that itself means you're on the right track. So today we're going to talk about obesity under BNF Chapter 1, Part 8. Make sure you watch this video till the end, because by the end of it, you'll clearly understand every single BNF point, explained in the simplest way possible. Now let's slow down and clearly understand what obesity actually means, because this topic is not only important for exams, it is extremely important in real clinical practice. First of all, you must understand one very important thing. Obesity is not just about body weight or physical appearance. Clinically, obesity is a disease condition that is directly linked to many serious health problems. When a patient is obese, their risk of developing cardiovascular diseases increases significantly. That includes conditions like heart attacks and strokes. At the same time, obesity is one of the strongest risk factors for type 2 diabetes, mainly because excess body fat causes insulin resistance. Obesity is also strongly linked to fatty liver disease, where fat accumulates inside the liver cells, eventually leading to inflammation and fibrosis. Many obese patients also develop gallstones, and another very common problem is gastroesophageal reflux disease, or GORD, due to increased intra-abdominal pressure. But obesity does not stop at physical illness. There is also a strong link between obesity and psychological as well as psychiatric problems. Many patients suffer from low self-esteem, depression, and anxiety. So when you think about obesity, always remember this key concept. Obesity affects both physical health and mental health. This is a very important exam and clinical takeaway. Now let's talk about how obesity is classified. In adults, obesity is generally classified using body mass index, which we call BMI. According to standard classification, obesity is defined as a BMI of 30 kilograms per square meter or more. However, BNF gives us a very important warning here. BMI should never be interpreted blindly. Why is that? Because BMI is not a direct measure of body fat. It only uses height and weight. In some people, BMI can be misleading. For example, very muscular individuals may have a high BMI but very low body fat. On the other hand, patients with muscle wasting or muscle weakness may have a normal BMI even though they have excess body fat. That is why BMI alone is not enough. To improve risk assessment, BNF recommends also looking at waist circumference because this gives a much better idea about central obesity, which is metabolically dangerous. So, when waist circumference increases, the risk of obesity-related complications also increases. In men, a waist circumference of 94 centimeters or more indicates increased risk, and in Asian men, the cutoff is lower at 90 centimeters. In women, a waist circumference of 80 centimeters or more already indicates increased risk. When waist circumference becomes even higher, the risk becomes very high. That means 102 centimeters or more in men and 88 centimeters or more in women. Here's an important exam tip for you. Waist circumference reflects central obesity, and central obesity is strongly linked to diabetes and heart disease. Now let's move on to the aims of treatment. The goal of obesity management is not rapid or extreme weight loss. That approach usually fails and causes harm. Instead, management should focus on modest, sustainable, long-term weight loss, and most importantly, maintaining a healthy weight over time. Why is this so important? Because even small sustained weight loss can significantly reduce the risk of type 2 diabetes, hypertension, and cardiovascular disease. Next, let's look at the overall approach to management. Obesity should always be managed in an appropriate clinical setting by trained healthcare professionals. Regular monitoring is essential. This includes checking body weight, blood pressure, and blood lipid levels, and actively screening for conditions that are commonly associated with obesity. Before starting any treatment, a proper initial assessment must be done. We must first check for underlying causes of weight gain, such as hypothyroidism. At the same time, we should carefully review the patient's medicines because many commonly used drugs can contribute to weight gain. Important examples include atypical antipsychotics, beta blockers, insulin in type 2 diabetes, lithium preparations, sodium valproate, sulfonylureas, thiazolidinediones, and tricyclic antidepressants. So always remember this exam rule. If a patient is obese, always ask, could the medicine be contributing? Now let's talk about the most important part of obesity management, lifestyle changes. Lifestyle modification is the foundation of treatment. This is first line and cannot be skipped. Patients should be encouraged to join a sustainable weight management program that focuses on behavioral change, increased physical activity, and improving diet and eating habits. Without this, no treatment will work long term. Now, what about drug treatment? BNF is very clear here. Drug treatment should never be used alone. Anti-obesity drugs must always be part of an overall weight management plan that includes diet and exercise. Drug treatment can be considered when BMI is 30 kilograms per meter squared or more if lifestyle measures have failed. Alternatively, it can be considered when BMI is 28 kilograms per meter squared or more if the patient has additional risk factors. In some patients, especially the elderly, younger patients, or those with poor dietary intake, vitamin and mineral supplementation may be needed. During treatment, response be regularly monitored and lifestyle advice must be reinforced continuously. One important thing to remember is that weight loss may be slower in patients with type 2 diabetes, so slightly less strict targets may be appropriate for them. Now let's focus on the key drug in BNF, Orlistat. Orlistat is the only anti-obesity drug recommended in the UK. It works by reducing the absorption of dietary fat in the gut. It is licensed for patients with a BMI of 30 kilogram meter square or more, or 28 kilogram a square or more with risk factors. Orlistat can also be used not only for weight reduction, but also to help maintain weight loss. Here is a very high-yield exam point. Orlistat must be stopped after 12 weeks if weight loss is less than 5% of baseline body weight. Other drugs that increase satiety, such as methylcellulose and stercuria, which is unlicensed, have little evidence of benefit. Many centrally acting appetite suppressants have been withdrawn due to serious safety concerns and addiction risk, including dexfenfluramine, fenfluramine, sibutramine, and rimonabant. Finally, let's talk about surgery. Bariatric surgery may be considered in severe cases of obesity. It is indicated when BMI is 40 kilograms squared or more, which is called morbid obesity, or when BMI is 35 to 39.9 kilograms square with a significant associated disease such as type 2 diabetes or hypertension. And very importantly, surgery is considered only after all non-surgical treatments have failed. Before you go, if this video helped you understand obesity clearly, that means you're serious about learning medicine properly. So don't stop here. Subscribe to the channel, like the video, and keep learning step by step with BNF. In the next video, Part 9 will cover rectal and anal disorders, explained simply and exam focused. Stay consistent, stay focused. I'll see you in the next lesson.